Yes. Hello, everyone. My name is Jong-Young Lee. I'm an interventional cardiologist, quite different from the all presenter and panelists. I know that you are the vascular surgeon mainly, but I'm an interventional cardiologist and working in Samsung Hospital. My main field is the peripheral and the CDO. So today's the title is the creating a successful endovascular practice, sponsored by Prof. Yeah, so I'm really happy to see and meet the very distinguished presenter from the worldwide, especially China, Russia, and then Singapore, etc. So we have the several presenter and one discussant. So Dr. Lu Shaoying from China, Dr. Dexter Chen-Yak Seng, Singapore, Dr. Ahmad Rafizi Hariz bin Ramli, Malaysia, Dr. Feng, China, Dr. Georgy Traiger from Russia. Once again, I'm very happy to see, and I will hear and will discuss about our practice about how to properly treat our endovascular disease patient. So first of all, I will start my presentation, and uh, basic frame is the 15 presentation and subsequent 5 minutes of discussion will be held. So after each presentation, everybody from here will give us some talk or the comment for each presentation and discuss from the for the 5 minutes. So first of all, I will start my presentation. So can you see my slide?
Yes, no problem.
Yeah, thank you. I will start my presentation. The title is the heavy calcified common iliac artery polarization in very high risk patient. Briefly, I introduced my patient, a 67-year-old gentleman, presented with the recent chest pain, hypertension, hyperlipidemia, and current smoker. ECG showed the non-specific STT, but showed the elevated troponin I level. So clinical diagnosis, nonetheless patient MI. Coronary angiogram showed the very tight stenosis in the mid to distal LAD. So in this situation, sometimes we recommend the bypass surgery because there are several bifurcation regions. But unfortunately, the patient refused the bypass surgery. In this situation, I put the stent from the proximal and distal with the drug corridor volume, very same strategy in peripheral artery disease. So during my coronary intervention, the right femoral artery was adopted usually, but right femoral artery pulse is too weak. So in this situation, I approached the left femoral artery. During that time, I asked my patient, is there some problem? So he expressed the severe photogear claudication. So, but he only consulted for the spine problem. So this is the baseline angiogram from the femoral artery approach. You can see here total occlusion in the common iliac artery was seen during the coronary intervention. So subsequent to the ankle brachian, they showed the much lower in 0.70 in the right side. Left side is normally preserved. So after PCI, usually we choose the depth using the aspirin and ticagrelor. But unfortunately, on the same day of the PCI, patient reported a very severe headache with nausea. We quickly checked the brain CT. You can see here, there was some brain hemorrhage. So after discussion with our neurosurgeon, we adopted the conservative treatment. But the headache and nausea was not improved, so we did the evacuation surgery. And then I down to from recovery to clopidogrel during the hospitalization. That final aspirin clopidogrel were chosen by our strategy. And I consulted to our vascular surgeon what is the optimal strategy for the team approach. My vascular surgeon explained to me the patient has the coronary artery and some ICH. So he said to me, this patient is too risky to undergo bypass surgery. So in this situation, my only choice is to do the endovascular treatment. This is the baseline CD angiogram. You can see a very highly calcification was seen in the mid body of the toral segment. But the reconstruction was seen in the near the iliac and internal iliac artery bifurcation. So this is the common iliac artery from the post-femoral artery approach. But as you can see here, the right, the proximal segment too short. So in this situation, the contralateral wiring was not easy, but ipsilateral right femoral artery was punctured by the under the sono guided, but also even though very hardest the wire went to the subintimal space. You can see here fluorospectrally, there was a very high calcification. The wire went to the subintimal, even though very hard wire. In this situation, we adopted some very same strategy from the coronary CDO, reverse curve technique. So in this situation, I pushed the very non-compliant Achilles high precision balloon from the ipsilateral. But even though the contralateral wiring was not succeeded, quickly switched to the brachial approach. Usually, radial approach also was adopted, but I wanted to take the stronger backup. So using the left brachial artery approach, so using the long 6 branch sheath, the wire also could not puncture the proximal cave. As you can see, as you can earlier in the CD angiogram, but there was a very high and heavy calcification in the proximal body. But fortunately, the wire, hardest one, hardest one. Oops. Not easy, even though, but about 1 hour of the struggling, the wire went to the subintimal space also. As I showed earlier, the ipsilateral wire also made some subintimal space, so the brachial approach wire went to that subintimal space easier. So we confirmed the wire position through the ipsilateral angiogram. So as you know, the iliac artery shows the very high risk of the rupture, especially in the stenting implantation. So I must check the IVUS, where the wire is located. You can see here, wire is located in the subintimal space. Very same concept from the coronary CDO, the reverse curve technique. Wire went to the through lumen, but distal side, the wire in the subintimal space. In this situation, the stent size and length was determined by IVUS, but very careful implantation of stent must be done because the IVUS showed the wire was located in the subintimal space. So self-expandable stenting was deployed very cautiously. In this situation, some interventions adopted the balloon expandable stent because there was a heavy calcification, but I have the big concern of the iliac artery rupture, so self-expandable stent may be more comfortable than balloon expandable stent situation. So 10 the diameter 10 and the length is 120 millimeter was deployed very cautiously. after several times, the non-compliant such as the specifically Achilles and LMS ballooning. Yeah. So, yeah. But there are some uncovered vision in the very proximal portion of the CDO body. So in this situation, I must deploy the one additional self-expandable bigger stent. Diameter is the 12 millimeter. The length is around the 40. So cautiously deploy. And this is the final angiogram. As you can see here, no extravasation and the balloon expansion was good. And also, I checked the IVUS, the stent deployment size, and the expansion, and is there any dissection or hematoma? But fortunately, there is no problem. Very distal, from very distal to very proximal edge of the stent. So immediately after procedure, I checked the ankle block index. The value was improved from 0.07 to 1.18. So much improved vascular status was seen. So ESG guideline showed how to approach the peripheral artery disease patient. So according to the anatomical characteristics, we must first recommend the bypass surgery or endovascular therapy. So also the ESG guideline, especially in euro-iliac region, the shown region, they recommended the endo first strategy, but there must be the big complexity in anatomical region. They recommended the bypass the first strategy. Also, even though the very old classification from the task, but this anatomical classification may be very helpful to guide which strategy will be more adequate. Yeah. So sometimes I know that the open surgical strategy showed the very nice long-term patent rate, but especially in iliac artery region, endovascular also the very wonderful and very nice the long-term patients. So I think if possible, especially like my patient, if there is some high risk of the surgical treatment, I think the endovascular treatment may be wonderful option. So simple lesion, endovascular first surgery will be adopted, but more complex, we must persuade patient to the surgery first one. So this is my final slide. My key takeaways are the first one. Endovascular therapy would be a first strategy, especially high surgical risk patient, especially in iliac artery intervention. I think the IVUS is very, very mandatory, very same concept of the coronary artery intervention. So in this situation, usually in iliac artery region, there might be a high risk of the calcification and subsequent the risk of the rupture. So in this situation, very stabilized and careful non-compliant ballooning is really, really important to take the sufficient region preparation for the stent implantation. Thank you for your attention. Thank you. So I finished my presentation, and Dr. Lu Shaoying, do you have any comment or the?
Yeah, Dr. Jong-Young, it's a very interesting presentation. I think this case, iliac occlusion, is a very difficult case, especially because the heavy calcification. And my suggestion is when you already cross the lesion from crossover axis, why you remove the wire and choose the brachial axis? Because maybe you can use guide wire to cross the lesion, then enter a tube, through the wire, and then the upside down the wire can enter the aortic. Then you don't need to pass the lesion as a second time. So it will save your time because both wire crossing is under subintimal.
Yeah.
So I think if I'm the operator, maybe I only pass one time, then I use a tube to follow the wire to re-enter the aorta. Then maybe it will save your time. Yeah.
Yes.
Yeah. And I very agree with you. Maybe if you are a vascular surgeon, it's better to do a bypass. Maybe it's much better and safe. Yeah.
Thank you for your wonderful comment. So I totally agree with you. So yeah.
The result is very good. It's perfect.
Thank you. Yeah.
Congratulations. Yeah. Okay.
Usually during iliac artery intervention, especially stent implantation, I want to ask do you prefer in this situation balloon expandable or self-expandable?
Both. Especially when the internal iliac arteries was involved. Maybe it's better to use balloon expandable stent to preserve the internal iliac.
Yeah. Wonderful comment. Yeah. So if there is some risk of the sideways jail, so balloon expandable stent maybe better. Yeah.
Yes.
In our hospital, the balloon expandable stent was not much available, so the only option is the self-expandable.
Okay.
So yeah, so really during my procedure, also I have great concern, worry about the jailing of the internal iliac artery because the patient is not too old. So fortunately, iliac artery was survived, but yeah. In next time, if there is some same situation, I must use the balloon expander stent. Thank you for your wonderful comment. Thank you.
Okay. Thank you.
Do you have any guys? Do you have any comment or the discussion?
Professor Lee, I have a question.
Yeah.
I'm Dr. Feng from Beijing Friendship Hospital. I have a question. In the very certified lesion of the iliac artery, if maybe we cross the lesion by the dissection. So usually in your hospital, you use the curved stent or bare stent.
Yeah. But as you mentioned, some doctors prefer the curved stent. You mentioned. Yeah. Unfortunately, in Korea, in our nation, the curved stent only could be reimbursed by the rupture case. Yeah.
Usually in China, the IVUS was not usually used in the vascular surgery. Its use was limited by some other series. So usually the long lesion or the very satisfied lesion, or we cross the lesion by dissection or not in the true lumen. Usually the cover stent was the first selection.
Yeah.
Okay.
When it comes to patency rate, the iliac artery, so any type of stent shows a very similar patency rate, but as you mentioned earlier, during the procedure, I think the curved stent may be more give the more safe the feeling because the usual bare stent can make the late time of the extravasation. So in this situation, the curved stent maybe can heal some delayed risk of the extravasation. So iliac is too risky. Yeah, I agree. Thank you.
Very good case.
Thank you. If there is no more comment for my case, so we will move to the next presentation. So I introduce the next presenter, Dr. Dexter Chanyak Seng. The pronunciation, sorry, from Singapore. Yeah, he is the consultant of the Department of General Surgery in Kutek Wat Hospital in Singapore. Also, he is the member of the Society for Vascular and Electrical Surgeon in Singapore. Dr. Dexter, are you ready? Dr. Dexter?
Okay. Can anyone see my screen?
Yes, we can see.
Okay. Let me just...
Yep.
Okay, so once again, thank you, Prof. Lee, for introducing me, and thank you, Rosemet, for inviting me to this webinar. So today I'll be talking on the use of the Achilles, Castor, and Tri-Wedge as a complement in the endovascular therapy. I'm a vascular surgeon myself. So I think we have, in previous sessions, we've always been talking about compliance, about semi-compliant balloons versus non-compliant balloons, and how pressure affects size as versus rigidity in non-compliant balloon versus that's a semi-compliant balloon. And as we know, with a semi-compliant balloon, because of the dog boning effect, there can be a risk of dissection. Hence, people postulate that maybe non-compliant balloons will help to reduce such incidences. So I'll be talking about 6 cases in total, 2 AVF cases and 4 lower limb cases. So I know that 15 minutes is rather short, so I'll go through them quickly. So the first case is a 76-year-old Indian female, long list of medical history. As mentioned, she had a left brachiocaphatic arteriovenous fistula created in 2019. And this was complicated by recurrent thrombosis of the V needling site, and had 2 procedures in the last year or so. So once again, she presented with thrombosis of the AVF. And a still image, pre-angiogram shows the thrombosis, as you can see down there, with the AVF still draining via the basilic vein and via collaterals. So in our center, sometimes we do use an angiojet for very heavily thrombosed AVFs. And this is, you can see, it's the angiojet catheter going through and RTPA given. On the angiogram below, I know the image is a bit fuzzy, but you can see that there is the recurrent stenosis at the V needling site once again. So initially we tried with a non-compliant balloon, but that didn't really efface and with a residual wasting. So decided to go with a scoring with a Tri-Wedge balloon for the recalcitrant lesion. As you can see down there, pretty good effacement of the lesion, the whole balloon being effaced, and quite good luminal gain after the effacement of the balloon. Subsequently, the lesion was plastered with a Mustang as well as another 8 mm balloon to give additional luminal gain for this patient. And the completion angiogram showed a very good result with no filling of the collateral basilic vein and very fast forward flow via the main BC AVF itself. So moving on to the next case of the use of the 018 Achilles and the AVF. Usually for most of my AVF cases, I tend to use a 035 system, but in some instances where there are very tight stenosis, you might need to use 018 wire, especially when the 035 wire cannot get through. So in this case, it's a 54-year-old Malay female, once again, whole list of medical problems. With regards to her dialysis access, she had a left BC AVF created in February 2021, and this time was referred because of decreasing access flows and high A pressures. So did a retrograde puncture for this patient. However, for some reason, none of the wires, including an 035 and 018 wire, could get through via retrograde approach. So I decided to puncture antegrade pretty close to where the anastomosis was, and as you can see via a microcatheter sheath, there is a web down there that's actually stopping the wire or even a catheter from going through. Hence, with an 018 wire, managed to get through the lesion, and pre-dilatation with an Achilles and subsequently a 6 mm balloon allowed quite good effacement and of the web down there. And from the retrograde approach, we then managed to use another balloon to actually expand the lesion further. In completion angiogram, once again, there was pretty good flow to sort out the juxtaanastomotic stenosis, and the patient hasn't been back ever since. So now moving on to lower limb cases. So in the first case, it's a case of a SFA stenting in a calcified vessel. So this is a 66-year-old female. All patients presented are CLTI patients, in other words, either with tissue loss from either Rutherford 5 or 6. This patient has a whole list of medical problems, as you can see. And on the right side, she even had a previous angioplasty as well. However, this time she presented with a left foot second web space ulcer, and following pretty low TBIs as well as ABIs. So you can see down here, there's the second web space ulcer, and the ultrasound duplex shows that there is this calcified lesion in the SFA and pretty bad runoff as well. So initial angiogram showed a pretty bad calcification and occlusion of the SFA, and below the knee, you can see that there's also a P3 lesion as well. Tried to go antegrade initially, but was unable to cross. Therefore, decided to do a retrograde approach via a puncturing P1, and managed to cannulate from the retrograde approach. Initially, I used a non-compliant balloon. However, that burst on me, and I had to switch on to using an Achilles 4x150, which gave quite good effacement of the lesion, even though it's a very calcified lesion, and the balloon withstood the calcifications very well. And I was subsequently able to dilate do a pole bar with a 5 as then the 6 mm balloon. So post balloon dilatation, there was actually pretty good flow. However, because of quite a bit of dissection, despite the non-compliant balloon, I had to stent the patient with a 90-dash stent, which is actually a sirolimus eluting stent. And completion angiograms actually showed pretty good flow after the stenting. However, she only has a single vessel runoff with the peroneal, which fortunately supplies the PTA as well as the DP. And actually just 4 weeks down the line, the ulcer has since healed and she's once again ambulating very well. Next up, we have a ATO Chinese male, quite a bit of history as well with smoking and COPD, presented with a 3-week history of a third toe gangrene. There's no toe pressures or TBI to speak of, unfortunately. And the initial angiograms in this patient once again showed a pretty bad stenosis and a short segment CTO of the SFA. This time, I was able to cross antegrade, and as you can see the runoff, there's a CTO of the ATA with no distal reconstitution and a short segment CTO of the PTA, and multiple stenosis along the distal PT as well. Once again, managed to pole bar the lesion, and below the knee, I decided to use a non-compliant balloon with the Achilles 2.5 and the sequential dilatation to about 3 mm itself. And in the distal segment as well, used a 2 and 2.5 Achilles. And that gave a pretty good runoff, as you can see, with a very large PT now, all the way down to the foot. He subsequently had a third toe amputation, and the wound healed. However, he did come back with 1 episode of acute limb ischemia on the same leg because it was non-compliant to his anticoagulation, and it was a thrombectomy was done, and the rest of the previously angioplastic vessels were actually all patent. Next up, we have a 61-year-old Chinese male, once again, extensive past medical history of end-stage renal failure, diabetes, and actually had a previous amputation of TMA of his foot. However, he had this recurrent neuroischemic wound over the plantar surface of his right foot. And as you can see the image down there, this was also precipitated by non-compliance to offloading. This is the duplex. It initially didn't seem too bad. As you can see down here, multiple segments of stenosis. And this was at the point in time when I started learning to use the IVUS for peripheral arterial disease. Unfortunately, I don't have the images here. I'll be using opticoscopy. I'll use it to size as well as to check my vessels to make sure that we can actually size them properly, as well as to look for any dissections to see whether there's a need to stent them. Managed to get through antegrade. Once again, use the non-compliant balloons. And then, however, there was a dissection noted as well, but with that resolved with prolonged dilatation. In the popliteal segment, I tend to be a bit more careful and I try not to stent it. So I tend to use non-compliant balloons down there with prolonged dilatation because the popliteal, like the CFA, are one of my no stent zones. So I'm trying very hard not to get any dissections around that area. And below the knee, multiple angioplasties for him as well with the Achilles. As you can see, a completion angiogram, pretty good result with almost a 3-vessel runoff for him. The TMA wound actually healed, and he's been well ever since. The last case I'm presenting is a case of a 41-year-old male, once again smoker, multiple medical issues, presented with a toe abscess this time on the left side and quite low toe pressures. Duplex down here shows a severe stenosis in the FA proximally and a trifurcation disease involving all 3 vessels proximally.
Yeah.
So as you can see, these are the angio images. Not too bad in an SFA actually, and subsequently with good dilatation of the vessels. Once again, we're using in the popliteal segment with a non-compliant Achilles balloon.
Yes.
And even below the knee with Achilles as well as another non-compliant balloon. Had very good vessel runoff in the trifurcation disease, with also once again good 3-vessel runoff. And the wound has since healed and is back to work. So I think Achilles and Castor have pretty good several benefits on the balloon. It's firstly quite a standard with pretty good gaussing profile, and it's very durable. And it's also quite strong, as you can see that I've shown the case where there was previously blasted with a very good outcome, even though another non-compliant balloon had burst. And the other good thing is that we're able to reuse these balloons multiple times. And from the price point in Singapore, at least, Achilles and Castor are actually cheaper than several of the other competitors. However, there are certain things that I do wish for in Achilles and Castor in Singapore, specifically longer length balloons, because the longest length we have here is 150 mm. So, I mean, there are several other balloons which are as long as 240 to 300, and something that which would be quite nice to have. Likewise, not always do we also have a 6 mm Achilles in Singapore, and it would be good to have one down here. So thank you for your time.
Thank you. Wonderful presentation and very interesting and very successful case from the Dexter Jong-Young. Wonderful, yeah. So I am very happy to see the wonderful procedure. You showed the very tough case, but you did a wonderful result using especially Achilles and the non-compliant balloon. So open discussion for all presenters and panelists, especially Dr. Lu Shaoying.
Yeah, Dr. Chang, a very good presentation. My question is, I noticed that the first case you used sirolimus eluted stent.
Mm-hmm.
I'm interested to that stent. So in China, we only have paclitaxel stent like Illuvia from Boston Scientific.
Mm-hmm.
And I was known, the sirolimus stent was freely used in femoral popliteal lesions, because most of the doctors think which has a very low long-term patency rate. And so my first question is, if you have a choice between paclitaxel elute stent compared with sirolimus, which you prefer to use?
Yeah, so actually I've always been a user of Illuvia and other paclitaxel-based stents as well. I think I've only started using a few cases of this sirolimus-based stents because there was the previous meta-analysis by Cortanos that said that there was a higher risk of mortality with paclitaxel-based products. So that's why there was this interest in using sirolimus-based stents. The sirolimus, the 90-dash stent is actually an iteration of the CREATE stent, the coronary stent that has since been used for peripheral vascular disease. One of the benefits of this stent is that it has 150 length versus the Illuvia in Singapore, which is only up to 120. So if I want to use fewer pieces of the stent and I decide to use a drug-eluting stent, sometimes I will consider a sirolimus-based stent, just preferably because of the length. There is a trial known as the Illumina trial, which has been done on Rutherford 2 to 4 patients. However, I think more studies need to be done to look at this group of patients which I'm treating in Singapore, which are Rutherford 5 and 6, whether it really does have a benefit. But in short, I think my main interest in using this sirolimus-based stents are also because of the length and I think the initial concerns of mortality with paclitaxel-based ones.
Okay, thank you. My second question is, I noticed that most of your patients are elder patients. If they cannot suffer long-term procedure, do you prefer to use POBA than use drug-eluting stent, or debulking then DCB then bail-out stent? What's your routine work?
So in my hospital, I actually do my procedures in the cath lab. So all my patients are actually under local anesthesia as well, so they're all awake. So I try to keep my procedures as short as possible. My indications for using arthrectomy or stents are really clinically based, not really about whether I need to shorten the procedural time. If I feel that there is a calcified lesion, for example, that might benefit from arthrectomy, I still will proceed with arthrectomy. And most patients, surprisingly, are able to tolerate it quite well with some form of sedation as well as analgesia. And likewise, for stenting, it really depends on how bad a dissection I get after a CTO, whether I'm in a subintimal plane, for example, and what is the luminal gain, whether I have recurrent wasting as well as after a POBA. So my algorithm of whether to stent or do an arthrectomy is dependent on clinical reasons rather than just the time alone.
Do you often use below the knee stent, below the knee artery? Do you often use stent?
I tend to do below the knee stenting mainly for bailout cases. In other words, tend to do it when there is recurrent dissection or coiling, even though there's a high pressure POBA. Or so if despite prolonged dilatation, if I note that, for example, at the AT origin or the PT origin, there is still quite bad dissection and has only maybe one single vessel runoff, I would try to preserve that as much as possible and would use a below the knee stent.
Thank you. Thank you very much.
Do you also use the atherectomy such as rotablation for the below the knee region? Sometimes we can see this, we can meet the very eccentric calcified region in the below the knee situation. So do you have any experience for the rotablation in the below the knee?
I haven't really used not rotablator for example specifically, but we have this other device known as the Phoenix. It's from Philips.
Yeah.
Yes, I have used that before for this, as what you mentioned, eccentric lesions where the wire can go through, but sometimes the balloon cannot go through because it does have a full arthrectomy function. Helps to debulk this very eccentric lesions to allow me to get good luminal gain for POBA. But not
in
routinely.
Korea. Yeah. Thank you. In Korea, in AVF, even though the stent is not reimbursed by government insurance, so we can use the only DCB or the plain balloon. So I think the long-term patency is not good. So as I saw your presentation, I must strongly urge my government to reimburse the drug-eluting stent, such as the sirolimus. Yeah, wonderful. Yeah.
Thank you.
Yeah. Is there any comment from the other participant? I hear that. Yeah. Go ahead. Yeah.
Yeah, Dexter, thanks for your presentation. It's quite nice cases. With regards to AVF cases, I think if you encounter a non-effaced lesion after POBA, I mean, what's your algorithm? Whether do you go for a more ultra-high pressure balloon or a scoring balloon or even a cutting balloon? So what's your go-to weapon of choice?
Yeah, thanks, Prof. Rafizi. I think there are two things. One, sometimes it depends on which balloon I decide to start off with. So If I tend to start with Mustang, for example, sometimes I will use ultra high pressure athletics to efface the lesion, failing which they might use a cutting, purely because sometimes there are packages that are being offered. So likewise, if you to use Dorado, for example, and it doesn't efface, then I might move on to a Conquest. Well, once again, this Tri-Wedge, for example, is also a good adjunct to help to efface these recalcitrant lesions. Despite cutting or scoring and these balloons, if ultra high pressure balloons, they do not efface, then the last better option would be to stent such lesions, but knowing which there's high risk of recurrence again.
Yeah. Okay, thank you. We move to the next present. Thank you, Dr. Dexter Chen-Yak-Sing. Thank you. So let me introduce the next presenter, Dr. Ahmad Rapji Hariz bin Ramli. So his title is the Optimizing Peripheral Intervention with Tri-Wedge Scoring Balloon. So he is the consultant vascular and endovascular surgeon of University of Malaysia, Specialist Center UMSC. Also, he is the honorable member of the International Staff Surgery. Dr. Ahmed, please.
Okay, thanks for the kind introduction, Prof, and also thanks, Prof Matt, for the kind invitation. Okay. So I'm just going to talk about optimizing peripheral intervention with Tri-Wedge scoring balloon, just to share some of our cases. Okay, so I think in our practice here in Malaysia, I think the scoring balloon and also the non-compliant balloon has been quite beneficial in our setting. It's actually correspond or actually improve the outcome of our endovascular prowess. So, however, we need to decide where does this scoring balloon, I mean, especially like Tri-Wedge, where does it come in? I mean, normally we know, I mean, the algorithm, whether if it's a high acute recoil vessel with POBA, I mean, maybe we can put in a stent or ISR, maybe you can put in either a covered stent or drug elution stent. But for high calcium load, then this is when I think scoring balloon does play some role, and even a tracheotomy device. And if having a mechanical force issue, then stent design play a role, and also compliance and surveillance is utmost important as well. Okay, in terms of the scoring balloon, mainly I will talk about scoring balloon actually. So I think it has shown some benefit. I mean, this is another paper in endovascular therapy. It shows that it's effective in restoring acute lumen gain and also prevent severe arterial dissection in a Feng population. And also a long-term outcome for treatment of calcified lesion in the lower limb. Having said that, this is a different scoring balloon, which is the angioscope. It's not available in Malaysia. Unfortunately, but according to this paper, I think it plays, it shows significant outcome in terms of the long-term patency. How about Tri-Wedge? I think we know Tri-Wedge is a non-compliant scoring balloon. Its IFU is mainly for stenotic, iliac, femoral, and also popliteal lesion. And some actually use it for renal arteries as well, and also can be used in the AVF and AV graft. I think those are the design. As you can see, there is the triangular element scoring system, which is made out of metal, and also is protected by this the folded balloons. And this is the device, and also and in the angiographic setting, as you can see here. So there is 4 markers that you can rely on to, so that you know where exactly the balloons end. Okay, compared to other scoring balloon, I think Prosmet Tri-Wedge have their own benefit. I think it comes with the 018 and 035 system. I think, having said that, I think the delivery is still, for me, I would prefer if the catheter length be longer than 75, maybe 135, so that I can treat, I can go crossover and things like that. And also the Brosmet, I think is a non-compliant balloon, so it tends to go higher rated burst pressure, which is beneficial in terms of scoring calcified plaque. Okay, just to share, so the first case is a lower limb case. I think it's quite standard case where got a lady here, 50 years old with, of course, diabetic hypertension and stage renal failure. So you will expect there is going to be a calcified vessel. Had a re-amputation, which actually poor heel. So ABSI is 0.5, less than that. So this is the run. So we did the antegrade puncture. So not too bad. I think there is a stenotic segment in the popliteal area there. So those are the stenotic area, mainly is at the popliteal area. So normally for this popliteal area, I mean, if you go too aggressive, then there is a problem where we have to stand by a bailout stand. In this situation around the popliteals, you want to try as much as possible to avoid stenting because you may end up with having to deploy a Supera stand or maybe a live stand on that area. So we decided to use a scoring balloon in this setting. So the lesion is not too, it's not a really long occlusion, so it can easily pass with the 018 wire, as you can see there. So just to highlight the Tri-Wedge operation instruction. So basically, when you inflate the balloon, you try to hold it 10 seconds. So in order to activate the wire function, and then after that, you have to gently or slowly inflate it over time so that it won't be, just pop out like that. So this is according to the operation instruction. So this is what we did. So basically, we just score those segments. This is using a 5x40. So as you can see, it fits nicely. Okay, so we decided to just carry on all the way to the SFA, and those are the run after the scoring. I think it's quite acceptable, and after that we just put in the DCB. So the first DCB is actually 5x100, and then the second one is 5x120. And then that's the final angiogram. So it's relatively acceptable. There's still some recoil or some wasting over there, which I think is not significant, and the contrast flow quite fast. And then the runoff is still preserved without any significant flow limiting the section. Okay, so I think we move on. Okay, so post-op, I think he had a good pulse. Having said that, the ABSI is still about 0.8, but the wound healed very well, and then he was discharged with a dual antiplatelet. Second case, I think this is a bit more complex one. 60-year-old Chinese female, got all these underlying comorbidities as well. Just a bit of clue that he also got the AF or rivaroxaban and digoxin. Came in with a poor healing left anterior shield ulcer for 1 month, and also rest pain. And ABSI is less than 0.5. So we did a CT scan for her. Focus on the left side. So this is a ring, quite long segment occlusion ring of calcium, and actually you can argue with me that there's possibly element of acute thrombosis there as well. So this is the angiogram set to go from the crossover. So as you can see, there's a abrupt cut off of the SFA there, which suggests there is possibility of thrombosis, and it can be crossed by this union catheter, and then there is also some thrombosis degree as well there. And we managed to cross the whole length and then get back into the SFA, distal SFA. And oblique and also the below the knee runoff is fairly okay. So not sure. I mean, this case was quite some time back, but I think we could have, what we could have done for this case is maybe we can just leave a catheter and then do a CBT overnight and then after that go back in. But at this stage, I think what we did was maybe it's not ideal. So what we did was we did a Tri-Wedge, and then because it's actually quite calcified, so we just did a Tri-Wedge the whole area, scoring balloon basically. And then after that, this is what we get. So of course, the flow is not good as well. But this is also is something like the acute on chronic limb ischemia because of the presentation. So after that, I think at this stage we decided to just use a longer balloon and see what happens. So that's the long balloon that we use, and then still the flow is not that great. Yeah. So and put in a stand thing after this. So we put in quite a long stand. I think this is probably an Everflex electronic stand. Also not that great. So I think definitely there is an element of thrombosis over there. So after repeated ballooning, still we weren't too happy about the outcome. I think we go ahead and, I mean, at that stage we don't have angiojet or any penumbra catheter available. So what we did was we just use the long sheath. So what we used was the Fortrex, because the valve can be open and then we can just suck it. So we managed to suck a bit of clot, and then following that, so we managed to get a nice flow over there, but it's not completely good yet after the suction thrombectomy. So we eventually put in the catheter CBT and then run this articulate overnight, 48 hours. And then we repeat the angiogram. So this is the outcome. So as you can see, we had to put in another stent until the SFA origin, actually. And then as you can see, the flow is quite good all the way to the bottom. So I think we learn our lesson basically for this case. I think we, I mean, it's best to actually just CBT first, and then after that we tackle it. I mean, once the thrombus resolved, right? But anyway, he said that patient is well, and then the wound also healed after the treatment. So next, I'd like to share some EVF cases. I think we did a study. This is I mean, small RCT that my supervisor, my master student doing. So I mean, we had like just 3 years for 3 years for him to complete the study. So funded by one of the companies here that do in the Tri-Wedge. So basically, I think I just crack on and go to the result, yeah. So based on literature review, I think not many studies actually look into AVF using a scoring balloon. Okay, mainly just a pilot study. Okay. So the primary objective is actually in the study actually to compare the 6-month post-expansion primary patency between the scoring balloon and also high pressure balloon. Okay. And the secondary objective to compare the clinical success, complication rate, clinical success between the scoring and also the high pressure balloon. So those are the data. I mean, we don't have that many patients. I think roughly about 60, 70. We are almost completing our study already. So this is just been the result. So there's not no significant between the different among the demographic data, except that I think there is a skew of the AVF technique, whereby in the high pressure balloon group we have more RCF, and then the scoring balloon, we got more BCF. So we are just thinking about whether we should extend our data gathering and then see whether we can actually balance this out. Okay, so in terms of the lesion characteristic, I think most of the lesion are single, but still we do have some multiple area of stenosis, and then most are at the swing segment. Complication rate, I think relatively both look quite low, but there is a tendency of the high pressure balloon is higher compared to scoring balloon, but it's not statistically significant. Technical success is more or less the same. Okay, so the outcome of follow-up, bear in mind that this is not completed yet, but as you can see here, the 3 and 6 month patency between the two groups is more or less the same, 95% and then almost 80% in 6 months. But at 1 year, as you can see here, the scoring balloon actually have a slightly higher patency compared to the high pressure balloon, which is about 70 versus 42%. Having said that, this is not completed yet, so it's not statistically significant as for now. So that's the survival curve. I mean, patency there, as you can see, there is a difference there, 6 months to 1 year. Okay, just to share 2 cases or 3 cases perhaps. The first case is elderly gentleman with diabetic hypertension and end-stage renal failure. Basically, he has weak thrill on the palpation, and then the duplex ultrasound shows reduced flow of about 300 ml per minute over the fistula. So this is the initial run. So as you can see, the juxta anastomosis area is quite stenotic. So we use Tri-Wedge 5 by 40 mm balloon at the swing segment. It's quite safe to use it at the juxta anastomotic area. So we balloon inflate up to 20 atm for about 2 minutes twice. Okay. And then this is the final outcome. As you can see, there's no rupture of the artery or the anastomosis, and then the flow is quite good following that. So that's the first case, and then as you can see on the follow-up, the flow has actually improved to about 600 mL per minute. Moving on to the second case, 60 years old female. She presented with bleeding at the cannulation site following dialysis, and then the duplex actually shows outflow stenosis. So this is the initial angiogram run. In this patient is my interventional radiology who did it. I think normally they would put in the granula first into the fistula, and then they just do a run before putting in a sheath. So as you can see here, the initial granula run, there is a stenosis at the distal to the cannulation segment with the collateral there, and then the cephalic arch looks pretty all right, and there's no CVO. So after converting into the sheath, this is a 6-fan sheath. So those are the stenotic areas. So I think they measure it. They actually use a 7 by 40 Tri-Wedge balloon. As you can see, there is still some wasting there during the inflation. But after a few inflation, and managed to open the lesion up. And then following that, the run is fairly good. Okay, so moving on to the third case, 71 years old male, poor thrill, pulsatile left BCF during the surveillance, the dialysis parameters, there is tugging, excessive low arterial pressure, and also high oxygen and high venous pressure. In this situation, I think the duplex ultrasound shows inflow and outflow stenosis. So standard, I think this retrograde access, and then managed to cross the tight lesion in the juxta anastomosis. Did a run there, as you can see, quite tight lesion over there with the post-stenotic dilatation. Outflow wise, the cephalic arch looked pretty okay, not too bad. So we managed to open the I mean, the juxta anastomosis with the 6x40. I mean, in this situation, I would actually not sure whether I was the one who doing this case, but I think what I should have done is actually settle the outflow first before doing this inflow, just in case that we run into problem with the perforation, things like that. But just for the sake of frequency, I think we just proceed that the Tri-Wedge 6x40 was used without any issue. As you can see, the flow improved. The anastomosis also improved as well in terms of the size. And as you can see, along the canalization segment, there is some degree of stenosis there with collateral formation. So in this area, we use 8x40 and then good effacement over there. All right, and then following that, the run is very good. All right, so I think that's about it for my case sharing. And just to highlight about the study, I think it corresponds to the previous study done by Zeng and Ross, mentioned that the technical success rate is fairly high, similar to their study as well, with a low complication rate of using the scoring balloon. But we could not achieve a zero complication rate as them. Okay, clinical success is 100%, and the 12-month patency rate, I think is slightly better in the scoring balloon compared to the high pressure balloon group, which actually contradict to what they have. As a conclusion, I think scoring balloon such as Traiger is safe and effective alternative to conventional high pressure balloon angioplasty for fistula, and even for and also in lower limb is also useful, especially in multi-segment arthroscopic population, to avoid the using of without stent from flow limiting dissection. So I think with that, thank you very much for your kind attention, and I would like to invite everyone to our soon KL VAC, Endovascular Access Society, in conjunction with the VAC conference in Kuala Lumpur in September. Thank you very much.
Thank you, Ahmed. Wow, wonderful. You showed the very informative case at the SFA, DCB, and the subsequent beta stenting, also the role of the thrombolytic agent, and he showed his own data about the role of the scoring balloon compared to the high pressure balloon in AF vision. So wonderful presentation. Thank you. So I heard that there are more than 700 general participants in our webinar system. So if you guys have any comment or the opinion or question, please feel free to take a message in the chat area. So also we have the open discussion to Dr. Ahmed's presentation. Dr. Shaoying, please. Dr. Ahmed, if there is some need of the thrombolytic agent, is there any recipe for the drug concentration, because there are very several regimen of the thrombolytic agent. So do you use the Achilles, am I right?
Yeah, I use Artiplace, and we are quite comfortable of using it at the rate of 0.1 milligram per hour direct to the
Usually how long do you use the thrombolytic agent in such your case?
Normally, I mean, if we decide, I mean, to just slow bolus, then we can just do over 24 to 48 hours. I mean, if we need to reperfuse faster, then we probably will give maybe 2 to 3 milligram of bolus, and then continue the infusion for 4 to 6 hours and repeat the angiogram.
Okay. So generally, we have some concern about the deliverability or crossability of the scoring balloon compared to the usual semi-compliant and non-compliant balloon. So if you have any plan to use the scoring balloon, do you the mandatory step for the use of the smaller semi or the non-compliant balloon or no direct the scoring balloon?
Yeah, I mean, as you can see, some of the lesion is actually at the juxta anastomosis. So sometimes the balloon, I mean, is a bit bulky at the tip. So I understand that in your question whether is it easy to push the balloon across the lesion. So sometimes, I mean, in the past, I mean, in our study, we don't. I think one of the feedback from some of my IR colleagues is they had to pre-dilate with a very small 2 mm balloon to allow the scoring balloon to go through.
Okay. Also, finally, I note that your society will hold the brand new meeting in this September.
Yeah. So this is probably our fourth or fifth meeting, the Vascular Access Conference.
Okay.
Currently, we are collaborating with DC from Singapore.
Okay.
Yeah, so it's going to be a big meeting. So you all are invited to come.
Okay. Thank you for a nice introduction, your data, case, and your meeting. Thank you, Ahmed. Yes.
Thank you.
So we move to the next presenter, the Dr. Feng Hai. Feng Hai, the title is the Chinese experience with the Tri-Wedge scoring balloon. Shortly, I introduced Feng Hai. He is a deputy chief physician and professor of the Department of Vascular Surgery of Beijing Friendship Hospital, Capital Medical University. He is one of the committee of the Endovascular branch of Chinese Medical Director Association. Dr. Hai Feng, are you ready?
Thanks for Dr. Li's introduction.
Yep. Yeah.
我想呢，我用中文来演讲
So
我
I
这
will
个
present in Chinese.
OK，
So I present in Chinese
可能这样呢，我会表达的
so that I can express myself more precisely, and then I will join all the discussions later in English. So actually, in China, for the scoring balloon, we already seen some promotions from various companies, and also we have some experience. So I would like to share with you the several cases that we had.
我们都知道，我们现在在这个
And as we all know that for the lower limb,
这一段的
for the popliteal arteries, usually for the routine balloons, have some limitations because it has the stress force and also the bone-like shape will lead to a high percentage of dissections.
如果我们对于下肢动脉病变，
And for the lower limb lesions,
情况下，现在的对于支架的植入率的要求是
for the stenting, usually we do not have very high requirement. So I think through the balloon dilations, we would like to avoid situations like DEF, for example, the spiral dissections and others.
我们真实的世界当中啊，
And in the real world, for example, for this paper, it retrospectively looked at 621 patients.
有748
And 748 are the symptomatic new onset SFA that has received the PTA.
在这里边可以看到，
And for those cases or deletions, we found that from D2F, those are severe dissections, we found in total the incidence is 37%.
接近30%的患者
So it means that for 30% of the patients will need a bailout stent.
非支架区
So I think for the P1 to P3, if we put a stent, we also look at the long-term patency, which is not very very good. And then
DCB 也
we look at the DCB.
相对来说它的入选标准更为严格，
We look at different inclusion criteria, and because of the stricter inclusion criteria, so it has a relatively low dissection. But I think for the impact study or luminant, it also indicates that for grade D to F, for the CTO lesions, the dissection rate is around 20%. So that is why it has a high percentage of bailout stenting. So in order to reduce the dissection after PTA, we have been trying to find a solution. And for an operator like us, what we can do is to optimize the revascularization. So we would like to revascularize the true lumen. And if we cannot do the antegrade, but we will switch to retrograde as soon as possible, so as to reduce the dissection and or the long dissections. And for the second, we will look at the sequencing dilation of the balloons. So like what you said, we can start with a small balloon for dilation so that we can prepare the vessel. And then the vessel can adjust it to different pressures. So, and then we can dilate the balloons to the routine ATMs. So I think this will also reduce the dissections. And then the third is the gradual increase of the pressures. So for example, it's like a playing in Tai Chi in China. So we need to balance and be very subtle in increasing the pressures. So I think this can also reduce the dissections, and this is what we can do as an operator. For the selection of special balloons, that is also very helpful. So in early days for the calcified lesions, the cutting balloon from Boston Scientific has a chairing, but it is actually suitable for the short lesions, for the lesions less than 3 cm. So actually it can reduce the compression of the balloon on the lesion. So actually to reduce the severe dissection. So I think for the short lesions, this is good, but I think the compliance of that balloon is not very good. And I think that is also related to the design of the balloon. And then for the scoring balloon, we can see the development of the scoring balloon on the slide. So we found that there are about 70 scoring balloons registered in the market. And for the scoring balloon, I think one is from bromide, like what we have seen that is very widely used in Malaysia, that is a Tri-Wedge. This is has 3 stainless wires, and it actually has a very good scoring. And also this is a high pressure balloon. So no matter from the vascular tract, which has 2 wires, but it would be very difficult for them to dilate. And now we have actually a very fully dilated balloon. This is a very important improvement. So you can look at the Tri-Wedge. This is very special, and we have already heard from our Malaysia experts, so I'm not going into details. So I think for this Tri-Wedge, it has a very long working length, as long as 150 cm, so we can actually do the crossover. And currently the longest balloon length is 60 mm. So for the, I think it's similar to the function of the scoring balloon. I think for the CTOs, in order to have a better put through, we can use a small balloon for the pre-dilation. And then for the wires, so actually they are very good located so that we can have a very balanced force. And then for this 3 wires, it actually can dilate the lesions, and also the triangular wire design can actually have a better force, a focused force. So we can look at it, and then we can have a more even out stress. So this is what we are looking at the pump. So we can look at the pressures. So actually this is the mimic or the simulation of the vessel, and then we can look at the scoring. caused by the balloon. So we found that actually for the Tri-Wedge, it is a vertical and even out scorings, but then for the routine balloons, we found that it's a bit messy, so that it will also create the dissections. So this is what we look at it. So it has a very good, these three scorings, and the wires has a very good scoring. And then we found that these are the simulations. So for the angioscope, we found that this scoring is scattered a bit almost everywhere, but actually for this one, it's a longitudinal scoring, so it is better. So we look at this features of the balloon comparing to others. So I think no matter for the angioscope or the NIPRO and SE-PTA or the ScoreFlex, I think it's the similar scoring design, but I think actually for the wire and also for the scorings, I think every balloon is very different from each other. And then we found that these balloons, these are scoring wires, and it will not affect the pushability of the balloon. And also, actually, it has a much smaller diameters, so that we can have a better pushability of the balloon. And the other is the flexibility of the balloon. We found that comparing to other competitive balloons, we found it's more flexible. And also here, we can see that during the curve or the flexible, there is no angle. So I think it's better so that we can also have a better trackability of the crossing over. So like what we have heard from the AVF cases from the Malaysia professor, this is fully proved. And then I would like to share with you two cases to look at the Tri-Wedge. So this is a male 69-old, and from the CT, we can see that the lesion is not very complex. But then for the SFA to the popliteal, there is a very severe calcification. This is the baseline angle. So we can see that this is the lesion, and there is a segmental CTO. And then for the collaterals and also the deep femoral arteries, we have a retrograde images. And then for the below the knee, we still can see very clearly the images. And then because this is a very severe calcification, so we first choose the cutting balloon from Boston Scientific 5x20. We know that for the cutting balloon, it can has a very high pressure locally. And then after the dilation, we actually did not have very good achievement or gain. So I think the stenosis is still remain around 70%. So then from this lesion, we know that the lesion is relatively long. So we actually add another 5x60 Tri-Wedge. And after that, we actually dilated for 2 minutes. And we found that we have a better lumen gain, and that is better after the dilation. And then we can complete with the DCB. So we can see this is the pre-dilation, and then this is the post-dilation. So we found that we do not need to put a stent at the area, because usually the patency of the stent will not last long. Second is a very similar case. So we found that at the distal SFA and also P1, there is a very severe calcification. And this is very severe calcification that we can see on the image. So first of all, I think we have more toolkits. So first we use the shockwave, and we shockwave the local calcification, followed by a scoring balloon, so that we can have a better force. And I think this is very good for the P1 segments, and this is how we treat it. And we had a very good lumen, and I think this also avoid stenting.
Thank you so much. So this is my experience sharing of using scoring balloon for the severe stenosis cases to gain the lumen. Thank you so much.
Yes, thank you, Dr. Feng. You showed a very wonderful and very specific and unique and excellent properties of the Tri-Wedge scoring balloon, because the usually previous form of the such a this kind of the balloon have some their own limitation, but I think the Tri-Wedge scoring balloon overcome such the wonderful inherent limitation, especially the some flexibility, crossability, and deliverability, and also you showed the very the wonderful case, the use of the Tri-Wedge the scoring balloon. Thank you again. So also we have the open discussion time. Dr. Lu Shaoying, is there any comment or the discussion point?
对，我就用中文吧，因为那个冯教授刚才是用中文
All
讲
right,
的
I'd
啊。
like to make the comment in Chinese. So, Professor Feng,
球囊的我们没有用过啊。
we don't have this balloon yet,
它的长度
so
特别长，是吧？
I don't think the length is super long. So it's up to 60. The length is up to 60. So if it is a sub-interval,
能不能使用？
if it is a sub-interval, can we use tri-edge? Will that be effective if we pass the wire sub-intermally? So, Professor Lu, I think that ideally you should put it into the true lumen. If it is sub-intermal, the result is uncertain. So from true lumen to sub-intermal and back to the true lumen, so maybe the balloon can be helpful in getting the breakthrough point, and you don't need to be that long. And also another issue is the fibrotic plaque. For the fibrotic plaque, I'm not sure if it is useful or not. I think that so long as it's not a kind of a bony calcification, I think that this balloon should be effective. So for the fibrotic plaque with a kind of a fibro ring, will that be helpful? Actually, we are worried about the elastic recoiling after the dilation. Actually, this is a high pressure balloon. It's up to 20 atm. So with some complete dilation, we can have enough pressure, and also it has enough pressure on the fiber, and then the recoil will be minimized. So the key issue is to choose the right size, the diameter, and also choose the right pressure. And then when you can break the fiber, it will be less likely to have a recoil. So the three wires, actually the three wires are very small. I think that is 0.19 millimeter. 0.19 millimeter is the size of the wedge. So what if we somebody would like to make it bigger? For example, to make it bigger to 0.25. So it's like the cutting balloon of Boston Scientific. It's another story. So just like the professor from Malaysia said, the ability of passing the curve, for example, in the AVF will be pretty poor. So that's why in the Tri-Wedge, the wedge or the wire on the top should not be very big. Otherwise, the ability to pass the curve will be compromised. So can we use one balloon to have a sequential dilation? With the wire on the top, the trackability may be a little bit poor. So you can do some pre-dilation. You don't need to do the sequential dilation. You just need to dilate for once with the tri-edge, and you can get the job done. So for example, in the end, if you are going to target 5 or 6, you just need to get a 5 or 6 balloon tri-edge to just have a one attempt of dilation, and you can have the enough result. So my question to Professor Feng is that I come from Singapore. I'm not sure if you have used the vessel, the Tri-Edge for the vessel below the knee joint. Any experience? And also the rupture of vessel. Have you encountered these complications? To answer your first question, we never tried the Tri-Edge in the below knee vessels. We have two scoring balloons. The first is a Tri-Edge, Tri-Wedge. Another is the competitor's product. So theoretically speaking, all the scoring balloon actually has a triangle shape. So actually they are not very big in the size. So just like Professor Lu said, if we pass it in the true lumen, usually there will be a no rupture risk. Unless there is a calcification point, which is actually located close to the point, close to the point of getting into the subintimal space, then there may be a risk because this is area when you pass the balloon in. Otherwise, we don't think there is a high risk so long as the balloon is in the true lumen.
Intervention. So we don't have any confirmative answer to use of this kind of the device. So we must be careful about the use of the 70%. But as the Dr. Feng said, so the transition zone, I think that this type of the device may be very helpful to open some space. So thank you for wonderful presentation and the explanation for the such device. Thank you. Yes. So let us move on to the next speaker, last speaker. He's the first away from Russia, Georgy Traiger. His topic is the Russian experience with using Brosmery PTA balloon. Let me introduce briefly. He is the vascular surgeon of Rim Service Center at RGD Medicine, Semasco Hospital. Also, he's a very famous representative of the Russia, the Vascular Surgeon Society. Are you ready?
Yeah.
Yep. Go ahead, please.
Yeah. Good afternoon, dear colleagues. I'm glad to see you. Thanks for opportunity to participate the conference. It's really a great honor for me. First, I must say that you find me in the airport, and it may be some problems with Wi-Fi connection, and soon I need to check in on my flight. But previously, I want to tell you about our experience in use Grossmed device in vascular, endovascular, and hybrid surgery. The report is focused on the balloon catheters. We have discussed about the advantages today. And I'm going to show you our experience, but I cannot see my presentation. Do you see my presentation? Did you say it's okay?
No,
we can
because
see.
Where is my slides? I also can see it. Oh, it's a problem.
Yeah.
One moment, please.
Take it easy. If you are using dual monitor, so you must switch the first and second monitor.
Some problems. I'm very sorry.
You can share the full screen.
I can see it on my screen on my laptop, but you cannot see it. Maybe it's because of bad Wi-Fi connection. One moment, sorry. Sorry. Oh. Unfortunately. Such a good presentation with so interesting cases. I don't know why.
No, we can wait.
Just,
No problem. We can wait. So take it easy. Yeah.
I just write Max Wen from the Brosmet. I hope he'll help me.
Dr. Traiger, I can share my screen for you to play your slides.
Yeah, can you please start my slides because I can see it on my laptop. I
Yes,
start presentation, but
we can
I
see
cannot
your.
translate to.
Yeah. We can see. Yeah.
Okay, perfect.
So every time you need to turn to the next page, you can tell me.
Okay, let it be so. Thank you so much, and I'm very sorry again for this technical moment. Okay. Let's start. The report is focused on balloons, catheter by Brosmet. We have discussed about the advantages a lot today. Thank you to our colleagues. I'm going to show you our experience in vascular and hybrid surgery. The next slide, please. Slide about aim of our team. Slide number 3. I want to say a few words about our department. It's a Olympus Center in Moscow. Every doctor in our department is a hybrid specialist who is equally professional in open and endovascular pain of any type of stenosis and occlusions. We provide assistance patients with all type of critical limb ischemia in our clinic. So I will present you 4 cases. 3 of them will be endovascular only, and 1 of them will be a hybrid case with Brosmet device. The next slide, please. It's about patient A. We have a patient with occlusion of common and superficial iliac artery, first finger also. High risk it's a very high risk patient with a coronary heart disease and story of abdominal surgery. So that is why there is no place for open surgery. It's a better idea to make him an aorta femoral bypass. Only endovascular tactic will be preferred for patients. So what about tools? We choose 6-range introducer, 35 advantage guide wire, PIC and vertebral catheter. We use a left transbrachial axis for the iliac recanalization because of we try to not use the right hand. It's a better idea to go through the brachiocephal trunk, risk of stroke. So in 99% we'll choose left brachial artery. So we use guide catheter to support, for example, Vista 7th range, and a balloon catheter. In this case, it was Hermes 6 for canalization and for predilatation before stenting. In 99% cases of iliac artery lesion, we use stenting, not only angioplasty. In that case, we use stent seat EasyFlip 7 and stop. On the next slide, please, can you start a video? You can see the angiogram before stenting. It's a position of guide catheter. You can see the occlusion of iliac arteries. Do you see the video? It's okay? Sorry? Is video playing? Did you see the angiogram with occlusion? Because I'm afraid about quality of video. Did you see it? Sorry?
The video is not working.
Oh, why? Video on patient A, angiogram before stenting. Can you please try to turn it on? Because on my laptop it's work okay, and we testing it with Max, and it must work. And the second video after stenting, slide number 7. Oh, please don't say that you cannot see video. It will be so. I will write Max again, and
Sorry, I will
such a beautiful angiogram.
ending the sharing and restart. Sorry for a moment.
Yeah, can you please start with slide number 6 and start a video on slide number 6? We need to see angiogram with our colleagues.
Dr. Georgy, Hariz here from Malaysia. Hello.
Sorry?
Are you
Hello?
using a MacBook or are you using a Windows PC?
MacBook.
MacBook, no wonder. Because normally if you create a movie using a MacBook, it will come out with a QuickTime format. So if you want to play it in the PowerPoint in the window, normally they have to download the codec, or you have to convert your movie into another format. That's, yeah.
Yes, thank you, sir. I got it, but I have previously correct and we have testing it. This videos in PowerPoint, in Windows, and also in Mac. But now I start my presentation on here, and I don't know why it doesn't work.
Is there any space to skip your case? How about the random to
Oh, I have 4 cases, but all of them with angiograms. I'm afraid if you will not see these videos, I can only say that wow, we can make a very cool surgery. We are cool guys who can make any type of recanalization. But I need to show you video. If I don't do it, you will say, okay, maybe yes, maybe
we
no.
can easily imagine
No.
your wonderful works. Don't worry. Yeah.
Okay. Okay, let's talk about this patient.
The live streaming platform will share the slides, and once you would like to turn to the next page, you can give them the signal.
Please open slide number 6 right now for the colleagues. On my laptop, it works without any problem. Such a good case. But Max wrote me that video is okay. I don't know why. You must see it. You must see it because it's a very interesting case. The next patient will be with tibial arteries, very long and difficult recanalization. So you should.
This slide is made from the MacBook QuickTime player, but I think the current laptop is the Windows laptop, so I think the codec does not work. So.
Unfortunately. Okay, I will tell you story of these patients without video. So we use transbrachial axis, and we make full recanalization of iliac arteries. The distal was in the common femoral artery. You cannot see it on video, unfortunately. But it was very good clinical result. Patient removed from our hospital in 2 days after surgery. We don't move the patient to the intensive care unit after stenting. They go to our department, and on the next day they go home after stenting. It was very interesting case, but let's talk about the next patient, slide number 8, patient B, please. I would say about this case of tibial artery lesion, occlusion of anterior tibial artery and fibular artery, but patient with diabetes. So patient with diabetes and long-term local treatment without any effect, and doctors in a region say that only amputation they can offer to the patients. And he came to our clinic for another opinion, for a second opinion, and try to find help. So we try to use our endovascular methods with Grossman balloons. The next slide, it will be about tools. Slide number 9. About tools, only 5 French introducer, only a common guide wire, and Castor and Pollux balloons. Unfortunately, on the slide number 10, it's an angiogram before, and it's so interesting case, and you should see this video. Unfortunately, because it's a case angiogram before, when you can see only popliteal artery and nothing else. I hope our assistants will help with videos, or maybe they can send video in a chat and you can open it on your devices without Zoom, for example. I don't know. Now, slide number 10. Do you see the video of angiogram or not? Tell me, please. Sorry. Is angiogram? Don't see it. Maybe somebody will assist us with the technique.
Hi, Dr. Traiger. Can you download your slides on your laptop?
Yeah,
and share your screen?
I started on my laptop and it's all okay, but I cannot send it to the Zoom. I don't know why. In real.
You
Because
don't have to
we
send it
tested
to the
before.
Zoom. You can press the screen sharing button. Yes.
For example,
Can you find
did you see
on the lower 2 box?
One moment. What about video now? Did you see it? Sorry, Nis, maybe I don't know what the problem
Can you
is with
find
technique.
the screen sharing button? Share screen.
Yes, and
Yes, and share the full
yes.
screen. Yes.
Yeah, it's on the full screen. Yeah, what I have it on my laptop. I see the video of angiogram and oh, unfortunately.
Okay. So
Okay.
Yanis, the
if we
presentation will not be available. So we have the open discussion with Dr. Georgy. So
maybe I can show you only patient D. Please, can you open slide number 24?
okay, yeah.
Because on slide 24, it was no angiogram, only photos, only images. I will tell you about this patient, and after that, I will ask my colleagues to send my presentation in chat to email it to you, and maybe we can discuss it later. I really want you to watch this video and discuss with you about the case. I'm really interested in your opinion on it. Please open slide 24 about patient D. Yeah, I will tell you only about patient D.
Yes.
It was very interesting hybrid case. Patient. Slide number 23. Previous one.
Yes.
Slide number 23. It's a patient D with occlusion of iliac, femoral, and popliteal arteries. Total occlusion from the aortic bifurcation to the popliteal artery. We have only one way for him. It's a hybrid surgery because I have a history of bladder cancer with cystostoma. So that is why laparotomy and aortic femoral bypass is a bad way. And it was a very high risk patient. We cannot use open repair, only hybrid technique. So the next slide, 24, is a slide with our tools. So our classic tools for hybrid or iliac recanalization, as I said before, about left transbrachial axis with a guide wire, guide catheter for support, and Grossman balloon devices and seat standing. On the next slide, number 25, you can see pictures of situation before and after recanalization. It was a flash occlusion of common iliac artery with a distal on deep femoral artery. We make a standing of this zone, and after that, next slide with me and my colleague, slide number 26. Just my photo. We make bypass from deep femoral artery to fibular artery with using Grace Venous vein after stenting, and we have a very good clinical result. On the next slide, number 27, you can see the leg of a patient when he came to our clinic. Also in the region, our doctor says that only amputation, nobody can help you, it's a bad way, in Russian it will be "ой, всё," with no variants. But patient came to our clinic for a second opinion and trying to find help, so we can give him our hybrid method. And on the slide 28, you can see the clinical result when patient came home with that leg without any problems. He can find orthopedic shoes and goes walk himself, go for a walk with his dog and send us video about it. It was really cool. Very good result. With Grossman devices, it was very useful in transbrachial axis, as I said before. Unfortunately, only that case I can tell you in the presentation. And the next slide, I want to say thank you for all. Thank you for attention for all of you. And I want to visit. I want to invite everyone to our clinic in Moscow. It will be a great experience to work together in our surgery. I want to show our department. It will be really cool. If possible, I will very great to see you in Moscow and share our experience with you in live surgery, not just in the cases when I cannot present my angiogram. Colleagues, I'm very sorry. Thank you all.
Thank you, Georgy Traiger. Yeah. So we know that you are very doing well. So, but unfortunately, we cannot see your wonderful work in this time. But if possible, I think Brosmed can give us the more chance to see your wonderful work. So, okay.
Thank you. Thank you all. I want invite you to Moscow, and it will be great. It will be great.
Okay. No
Thank
worry,
you.
no worry.
Thank you a lot.
So we hear the all presenters, the wonderful case and the wonderful lecture. So Dr. Lushan, do you have any last comment or to some point to say or the participant or the presenter?
Professor Lee, Dr. Lu, our operation. Who
Okay.
Skills.
Yeah. So
I have a question to ask Dr. Traiger.
Yeah.
Can you give us a comment? The character of the bacillus catheter.
Character of the patient.
Bacillus balloon. The character of the bacillus balloon.
It was the first moment when I wanted to say about this balloon catheters is the great support, especially in tibial artery recanalization. We use 5 French introducer. We use no catheters, no vertebral catheters for support, only balloon catheters. For example, Castor. And it's very useful and make good support for recanalization, even in a case with total occlusion of febrile and anterior tibial arteries. For example, when you use, I don't want to say bad things about Abbott, about Boston Scientific, but in real, when we have long occlusion, total occlusion of tibial arteries, it's very difficult to make a good support in Boston and Abbott balloons. And I like this moment in Brosmed devices in real. It's my opinion, not only mine, my colleagues in our center, we use it. And the second moment, which I want to say before I need to go to my flight check-in, that it's very useful to use transbrachial access for recanalization of iliac zone and also an femoral zone. Because one of my cases, which I cannot present, was a patient with occlusion of iliac artery and distal part of superficial femoral artery. And we can use support guide catheter, for example, Cordius Vista, to recanalization iliac zone and the standicate. And after that, we use balloon catheter, which have 150 centimeters in long. And he make a good support for recanalization of femoral artery after iliac artery standing. So you can make all surgery from the one axis. You don't need common femoral axis for the recanalization of popliteal and superficial femoral artery. And it was very useful to use only transbrachial axis for iliac and femoral zone. There's 2 moments what I want to say that Brosmed device is really cool.
Okay. We all agree with your opinion. I think the Brosmed balloon catheter is really wonderful. Thank you for your excellent answer.
Thank you.
Yeah.
Thank you.
Have a wonderful night. So let me wrap up this symposium. Once more, I thank you all presenters from China, Singapore, Malaysia, and Russia, and all the audience from the all over the world. So today we can meet the wonderful case, excellent case, and a lot of the information about the Brosmed PTCA balloon. So that must be very helpful for the future clinical practice. So say goodbye and have a wonderful time in your life. Okay? Yeah. Goodbye.
Bye. Thank you.
Yeah. If possible, see you
Have
again.
a good time. Yeah.
Thank you.